Okay, welcome everybody to this webinar of ERKNet ESPN. It's the frequently asked questions on the subject of TMA. I'm very happy to welcome you here. Thank you for being with us today. And I wanted to tell you that everybody in this webinar is muted. And if there are any questions, please feel free to type them in the dashboard. It would be very nice and helpful at the end. First, I'm giving a warm welcome to our speakers. There are two speakers today, and the first one is the alleged Johan Vande Walle. He was a pediatric nephrologist at Ghent University Hospital, and he retired recently, but he is also still a member of the HHUS Registry Advisory Board and the International Task Force for the ERKNet guidelines. So he's very well known with the subject. Second speaker will be Aleksandra Vujovic. I hope I pronounced the name okay. And she is a pediatric resident at the University Hospital of Ljubljana, Slovenia. She is a PhD student. She has been a PhD student with a focus on complement inhibitors on patients with meningococcal infections. And she also had a research fellowship in Heidelberg. She is now engaged in clinical practice and research, particularly in complement diseases. So a warm welcome to both of you. And the first speaker I want to attend to is Johan Vande Walle. Please feel free to start the presentation. Thank you for coming.
Thank you, Ans. It's an honor to have you to introduce me, since what many will not know in the audience, we were trained together. We will have today a little bit a special session. I mean, traditionally we are giving more state-of-the-arts, what means we are giving the evidence and we are not speaking about our question marks, what many of you do want to know. And the second, we use a little bit the formula of the old crocodile and the young promising nephrologist. And I will go to frequently asked questions, but Aleksandra will demonstrate how we came to those questions.
Okay, feel free, Aleksandra.
One second. I had to, before we are starting, I had to say the next webinars. There is on the 14th of May, one of the overview of biostatistical approaches in clinical research by Ralph Hilgers. On the 18th of June, there is renal tubular acidosis by Detlef Bockenauer from Leuven. And of the 2nd of July, there is about familial hypomagnesemia by Karl-Peter Schlingmann. Now I will give the slides to my colleague. Oh no, what first? I'm not very well. What are the 10 frequently asked questions that we want to tackle today? First is when to start therapy. First, plasmapheresis, or should we go for immediate complement inhibition? What should be the duration of the therapy? Is the real indication only the proven complement mediated? Transplant patients, what to do? Then pathologic mutations versus non-pathologic variants. What is the truth about the malignant hypertension story? I will shortly tackle the postpartum versus TMA during pregnancy, the topic of secondary TMA, the topic of vaccination and/or antibiotic prophylaxis, and last topic, eculizumab versus ravulizumab. But Aleksandra, the word is now to you.
Thank you. Can you move to the next slide?
You should be able to do that.
Okay, yeah, so thank you for having me. My name is Aleksandra Vujovic, and I'm happy to present some of the results of our retrospective study. So to better understand the prescription patterns of complement inhibitors in hemolytic uremic syndrome, we looked at the real-world data from European Rare Kidney Disease Registry. So from 2019, almost 1,000 patients with hemolytic uremic syndrome have been enrolled, and 1/3 of those are atypical HUS, and 2/3 of those are infection-related HUS, such as Shiga toxin-associated HUS and Streptococcus pneumonia-associated HUS. So for our analysis, we included patients with available records on C5 inhibitor treatment, and those whose disease onset was after the year of 2011, so after the year of eculizumab's approval. And if some of the patients had a disease onset before 2011 and were treated with eculizumab, we also included them. So this yielded a cohort of 465 infectious HUS, and 261 atypical HUS. So the majority of atypical HUS were no cause identified, followed by the genetic causes and the autoantibody complement factor H HUS. Johan, can we remove this QR code?
Go to the next slide. Yeah. I don't know why it's coming up.
Okay. Yes, so what I wanted to say in the previous slide was that from atypical HUS patients, we had 261 of them, and 72% were treated with C5 inhibitors. And almost all of them, except for 4 patients, were started on eculizumab. And then 12% were switched to ravulizumab, 3% were switched to crovalimab, and 57% of patients that were treated were discontinued. And from that discontinued group, 14% were restarted on the C5 inhibitors. And then at the last visit, we saw that 94% of those that were discontinued were of state of treatment. So when looking at the treatment durations in HUS patients, we observed that the durations were longest in genetic HUS patients. So after 3 years of therapy, 60% of patients were receiving treatment, and there were no discontinuation for the observation time of 10 years. Shorter duration times were seen in autoantibody factor H HUS. So 50% of patients were discontinued after 2 years, and approximately 16% were treated after 5 years. And even shorter durations were seen in HUS with no cause identified. So 50% of patients were discontinued after approximately 1 year, and 20% were left on treatment after 5 years. Okay, yes. So one back. Yes. So among patients with genetic forms of HUS, the treatment duration also varied regarding their genetic findings. So in complement factor H patients and complement factor I, approximately 80% were on were sustained on long-term treatment, and in mutations with C3, 70% of patients were on long-term treatment, whereas in patients with CD46 mutations, we saw that approximately 35% of them were left on C5 inhibitors after 3 years. We also observed some varieties among European countries. So in countries on a more eastern side of Europe, such as Poland, Czech Republic, and Romania, we saw that after 9 years of treatments, 70% of patients have been still receiving C5 inhibitors, and we saw no withdrawals after the 3rd year of therapy. On the other hand, in France, we observed way shorter durations, with 90% of patients being discontinued after 2.5 years of treatment. So regarding the discontinued patients, so 108 of them, 14 were restarted. 14 were restarted on the treatment after a median of 10 months. And we confirmed TMA relapses in 11 of those cases. 8 of them had a genetic findings, so the majority of those were C3 and CD46, and in 6 cases no genetic cause was identified. So during the relapse, the mean LDH value was 850, and mean platelet levels were of 87,000, and the lowest mean eGFR was 36, including 2 patients that needed dialysis. We had so the patients had the full clinical recovery and also normalization of laboratory values within 2 months. And at the last visit, we saw that their mean eGFR was in the normal range, so 110. So in patients with infectious HUS, in our cohort, we had 465 patients, and 87 received C5 inhibitors. Most of them were on eculizumab, so that accounts for 19% of patients with infectious HUS receiving eculizumab in our cohort. And those treatment durations were relatively short, so on median for 3 weeks, and we had no patient receiving C5 inhibitor after 1 year. Okay, just a second. Okay, and in those patients that were, so at the last visit, we looked at the CKD stages and compared the patients with infectious HUS that were treated and those that were not treated with eculizumab, and we saw worse kidney outcomes in those that were treated with C5 inhibitors, which could be due to initially higher severity of the disease, which led to the C5 inhibitor treatment in the first place. So, thank you.
Thank you. You have seen from those data, what are real-life data within the ERKNet registry, that there's a big variation, very big variation between countries, probably between centers. So that must be some reason, and therefore we have formulated some questions. Don't misunderstand me if I say there's a large variation. Probably the variation is still bigger in real life, since within ERKNet, we all agree that there are mainly the so-called expert centers, and then the ones who are at the first application in that are registrating. Oh, this is a slide. So let's start. One of the big questions, and in many national guidelines, is still to do plasmapheresis. Let's split it up a little bit between children and adults. In 2009, the Working Group on Hemolytic Uremic Syndrome did write up guidelines how to do it. And about 5 years later, Sally Johnson did do a survey in those so-called expert centers, where you will see that only 80% of the patients did really get plasmapheresis, but only 13 patients of the 59 really did get it according to protocol. So the majority of patients who did get it did not get the volume, neither the frequency as prescribed. And one of the major reasons was, of course, that during weekends it's not always easy. There were technical problems, there were infections. And if you look into the results, I mean, then the hematological remission was only present in 80% within 1 month, so not fantastic. And in many patients did not fully recover. In adults, there is overall still, and in most of the guidelines, that plasmapheresis should be the first-line therapy. One of the reasons is probably also because of referral strategy. I mean, in many countries, you can give the drug only in expert centers at university, and there is quite some time between diagnosis and referring to the centers. I think adult centers also very much stress on the fact that they first should exclude all other causes before they are starting eculizumab, and they have certainly as argument as a lower complication rate for plasmapheresis. Although we still have to say it's not without risk. Even in adults, there is a significant percentage of side effects for this indication. Now, should we start with C4 indication? I mean, and what is the indication? It still remains clinical. Your genetics are coming too late. I mean, although some centers are having it now within 4 to 8 weeks, in the majority of centers, it's too late to do cytotherapy. And the complement tests are also too late. They are sophisticated. So the decision to start or not to start is as soon after the diagnosis, but you must have had the vaccination on the same moment already to be able to start, and you must also have excluded to the maximal the secondary causes. Now, does this give influence in results? In this study from Brocklebank, and you see here very clearly the difference between the blue and the red line. Yes, indeed, eculizumab gives a much better effect. But in this study, you can also see that it does not differ the effect anymore after 1 year. Now, you could say, let's wait a little bit until we have more diagnostic tests. But then I like always to come back to something that we know much better, and that's the VTEC hemolytic uremic syndrome. About over the last years, and I have taken here just 2 publications from Alconquer, it's very obvious that although many of us do think that typical hemolytic uremic syndrome in the majority of patients is benign, you see that after 12 years follow-up, a significant number of patients are ending up with CKD, even, excuse me, even in those patients who were not on dialysis. So in the early phase, I think we should act as soon as possible, because not every glomerulus will recover afterwards. Now, is it important to start early? In this slide, this is coming from one of the earliest studies, where we did look to patients started within 7 days or patients started more than 7 days. And you see here both on the platelets on the right side as on the left side on the GFR that it does make a significant difference. So if you want to start as soon as possible. Although this slide very much demonstrates the enormous gain in GFR, don't misunderstand if you see the standard deviations. If you are starting a little bit late, even if it's 7 days, probably not all patients are fully recovering. The next topic, the next question is now very hot. Duration of therapy. We must admit that this was not a part of the labeling studies. So it's not into the label to stop, but it's also not in the label that you should continue, because that has also not been demonstrated. And as we have seen, strategies are largely country dependent, tapering the frequency of the doses of interrupting. Let's go a little bit into the literature, and then I would like to come first back to the Dutch experience of the group van Nicole van der Kar and Wetzels. They have supported their strategy by proper pharmacokinetic and pharmacodynamic data. And in the Netherlands, they have a very selective indication to start C5 inhibition. And all patients do get full screening of all genetic and other factors. Now, the first publications from Volokina showed that you could taper safely the frequency down. So the same doses you could administer instead of every 2 weeks, every 4 weeks. In the next study, they studied withdrawal. And also that study demonstrated that in the majority of patients, you can safely withdraw the patients. So in the recent review by Weinsma, they go for really an individualization of their regimen, where you should try to stop. And I think they are stopping now in the majority of patients after 3 months, but closely monitoring for relapse, or that you can taper safely down in the more high-risk patients. Okay, the next big study that supports that you can stop is the French experience published by Fadi Fakouri, where they had different strategies according to the genetic severity, but where you clearly can see that, again, you can taper down, you can interrupt therapy in the majority of patients. So, if I may conclude, labeling studies did not study duration of the therapy. Fakouri documented the feasibility of discontinuation. The Dutch group documented that as well tapering down is possible, but also discontinuation is possible. And then it remains 2 options. You can say, I stop in everybody, and instead of relapse, we restart. Or you continue in the severest cases, what's the French protocol. But anyway, you can never fully predict who will relapse or not. We have to agree. In fact, the studies are still underpowered, and since many of us are doing it all according to an own protocol, it might be very difficult ever to reach the powering that we are really needing. The next topic that you hear often is you should restrict the eculizumab only to the proven complement-mediated diseases. But that's very difficult to discuss because the genetic mutations are now found in about 50 to 60% of the typical AHUS. In the others, we do not find anything, but they respond as well on eculizumab. And complement might certainly have an added value, but the tests that are available on this moment are not bedside available. So you can use those genetic and complement tests only afterwards to say, can I stop in an early phase or not? So those tests are too late. And I think that most of those TMAs include complement activation, although not all to the same degree. Another question is, of course, what to do with transplants. They were excluded from the labeling studies. So it is indirectly from literature that we can look. And it's clearly that this is the phase that we should document it, because with the increasing success of the C5 inhibition, probably we will have less end-stage renal failure in the future, and so less transplants. All studies that are published are very heterogeneous groups and have never been really matched in time. So often it's compared with historical controls. So if I look to, this was the, I don't know what's happening to my slide, but there was this French study from Suberg that clearly demonstrated the added value of prophylactic ACE inhibitors, prophylactic eculizumab, sorry. There is the Dutch study, although much smaller, who shows that maybe you should not even start in every patient preemptive if you treat when at the first symptom. It might early enough. However, TMA after transplant is not always easy to document. It's less easy than before transplant. And I took part in this study within the AHUS registry. We looked to the different kind of patients that were transplanted so far. And there are two groups, the diagnosis prior to therapy and who did get preemptive eculizumab, diagnosis prior to transplant who did get the drug after transplant. But there was also a quite important group where the diagnosis of TMA was only made after transplantation. Now, if you look to those results, then it's very clearly that there is a difference. Oh, so sorry, there's something going wrong in the projection. On the left side, you see the paper of the French Society, where they were demonstrating that a strategy where you are differentiating according to severity grade gives big opportunities. So, sorry for this slide, something went wrong in the projection. So if I take all the conclusions in line, then it's clearly that you can have a strategy where you are saying that high risk, we are doing them preemptive. The low risk, we wait until they are the first symptoms. But the studies from the registry showed, and of course it's not a controlled study, that if you start later, your NT-GFR risks to be lower. The next question is about the genetic tests. I think it's a big issue always. Is a variant rare and pathologic or non-pathologic? And this is something that we should, within the international community, decide. Until now, literature is already overwhelmed with a lot of variants that are demonstrated within TMA who have not documented that there is a causality link. So in this paper by Fakuri and Fremo Bacci, this is very well described. I think we should restrict to nominate a pathologic variant if it is internationally accepted. We should continue to describe the ones that we do find, but are not yet considered pathologic. Sorry, that's...
Johan, maybe you close the presentation and open it again. Maybe it's, I don't know.
Yeah, I don't know what's happening.
Is somehow... Do they look normal on this?
On this, they look normal. All. I do not understand. Okay, sorry. I hope it goes better now. So, about those pathologic rare variants versus the common variants that are, it's really important that we are not individually describe it, but that at least in an international consensus we make those definitions. Next interesting topic is the malignant hypertension story. The group of Maastricht about 7 years ago identified a group of patients who had malignant hypertension and TMA symptoms, and they found here mutations in several complement abnormalities. Since that moment, there have been multiple publications who found similar things, still in a very limited number of patients. It remains questionable if it's really worthwhile to test every patient with malignant hypertension for the genes. But in malignant hypertension, where you have a TMA clinical picture, it's certainly valid to consider them as potential ARGUS and to give the full screening. Now, if we are looking to the international registry, we have also tried. Oh, sorry, this is really, the slides are all mixing up. If we are looking to the
Johan,
international...
I have the slides from you. Should I share my screen?
Yes, please.
Let me see.
Because if I'm not projecting them, they are looking normal.
Do you see my screen?
Yeah.
Oops. Is this the right one?
Well, there's still the previous one.
This one?
Yes, okay.
Or you have to tell me.
Okay, so yes, please. So this one we have had. Yeah, next slide. So they have therefore tried to formulate already a different algorithm. And as you can see, they are putting here the hypertension together with the pregnancy immediately already in the TMA group. I would refrain a little bit more on the safe side on that, because I think the majority of hypertensions are not fitting within that pattern. And certainly in pediatrics, it's very rare that you have this kind of clinical patterns. Next slide. Does everybody see the slides now correctly? So in the registry, the August registry, we looked how many of those patients did have malignant hypertension. So it starts from the diagnosis atypical Hus with hypertension. And there is clearly that you have an increased incidence of kidney transplantation, increase of pathogenic variants in that group. And if we are looking in the group that was treated, if they are treated, they had clearly less kidney transplantation, and there is a lower incidence of variants. Next slide. Now, looking, it's something that according to the registry is mainly in the adolescents and young adults. So in the young children, it's very little present. Next slide. Sorry, next slide. This is not. The next topic is the postpartum versus TMA during pregnancy. I think this slide comes from Fadi Fakuri, and you see this is a very complex problem with a lot of things in differential diagnosis. And although there are some subpopulations, especially postpartum, that are at risk to have a Hus-like picture and the mutations, the majority of the so-called HELP syndromes are not TMAs that are complement mediated. Next slide. In that excellent paper from Fadi again, you see how complex we should do the differential diagnosis. But we have at least to consider 3 groups of patients today. And I think this is something that's worthwhile to have a whole webinar about, only about TMA and pregnancy. Next slide. But there are 3 lessons that we have to take, and that's part of that slide. I think certainly pregnancy is possible during eculizumab therapy without serious adverse events, and we should discuss that with our patients. It's clearly a different approach during pregnancy and postpartum, where the differential diagnosis is different. I think if you have it, and that you see on the right side, then if you have first to exclude Adams 13, the strategy is still now to start first with plasmapheresis. But if there's not Adams 13 related, then they're advised to consider it as Aghus, and indeed to start with eculizumab. The big problem is this is well known into nephrology, but the majority of deliveries are going in the local units where the knowledge about the disease is still very limited, except for patients who are under therapy. Next slide. What about secondary TMA? Well, there I have to say that evidence-based medicine is very low. There are believers and there are non-believers. VTEC Hus, and you have seen that from Aleksandra, although there's no evidence-based medicine, there's no label, and all studies have their limits. It's not so infrequent used eculizumab for that indication for the complement activation. And complement activation is there, but we should be aware that it's off-label and that as long as we are using it in the severest cases, what we are doing in the studies, and that's logical, the severest cases will always have the severest outcome. So it will be impossible to document that. In other secondary TMAs, it's even worse. There's no evidence-based medicine. I think there's some indices in some bone marrow transplantations. There are many promising cases. Often it's very short-term therapies, but in our registry, it's underreported on this moment, since the registry concentrates on the expert centers, and then mainly the pediatric TMA expert centers. This is something where we really should have an action point to be able to know more about this. Next slide. Within the registry, Christoph Licht has done together with the group an analysis how frequent it is. And again, the AHUS registry is Alexiom driven. So it's largely center and country dependent how many the atypical HUSs are there described. So they are certainly, the secondary atypical HUSs are described. So they are really underreported. Next slide. But here you are seeing in this that the most frequent cause considered to be secondary in a races is malignancy. And then you have pregnancy. Pregnancy, that is something that is now by the FDA demanded to collect all the data during ravulizumab. But again, not every patient with malignancy TMA or with pregnancy TMA will enter in our registries. Next slide. Big topic, vaccination or antibiotic prophylaxis. It's very clear you have to vaccinate properly with a booster 8 to 12 weeks later, with a booster 3 years, and then afterwards every 5 years. And I think you have to do it against all types of meningococcus. You have to do it against pneumococcus and Haemophilus influenza. Next slide. But despite vaccination, all reports document that vaccination is not protecting totally against meningococcal infections. And that's logical because there's a need for an opsonic activity for meningococcus. Many clinicians and public health agencies recommend, therefore, antimicrobial prophylaxis. And I think the first line and logical therapy would be penicillin. Does anybody know how you can get penicillin? If you see how expensive the drug is, we are not able to get the cheap penicillin. So what's then the alternative? And that's mainly driven by adult reports. They are giving macrolides or even quinolones. But we have already mentioned that many of our patients anyway have some CKD. If you're giving this kind of broad spectrum antibiotics, you are ruining your microbiome. And as I'm a believer that microbiome plays a major role in uremic toxicity, maybe that's not something that we want. We must also say that if you are giving long-time antibiotics, you are making resistance certainly available to the germs in those patients. And these are patients who have to go a lot into surgery if they are ending up in end-stage phase. So we don't have a good solution. And I think maybe the best solution is, and I'm coming a little bit to the beginning of my talk, is to use as short as possible eculizumab, because then you do not need prophylaxis, except in those patients who are having frequent relapses. Next slide. Next slide. So this is what I wanted to mention, the resistance. And I think it could be very helpful also to increase security by vaccinating the whole family as an alternative for giving long-term antibiotics. Next slide. Now, this is the incidence of the meningococcus according to a safety paper in 2019. And there you see that it is not so infrequent. That's the combination of patients with atypical HUS and with PNH who are getting eculizumab. And even the mortality, you can say it's very low, but of course it's still too high. I mean, but the incidence of the infections is quite important. Next slide. If we are looking to the populations age dependent, then you see it's mainly into the age group 16 to 44 that the highest risk is. It's less in the smaller children. Next slide. And of all infections that are happening, it's very clearly that meningococcus is the highest. So it's a risk that we are taking that we should not underestimate, and that we should take into the discussion. If you have for a mild mutation of an unidentified cause of TMA, you are giving, like Aleksandra was showing, 3-4 years complement inhibition. To have this risk, I'm not sure that it's worthwhile to do that. Next slide. Last topic where there's a lot of questions, eculizumab versus ravulizumab. Next slide. I'm using now some slides from the company. It's so that they have compared the effect of the complement inhibition between eculizumab and ravulizumab. And it's so that they have, with the new drug, an immediate and complete terminal complement during very long time. You see on the bottom the number of days. So it's very efficient in complement blocking. Next slide. Here you see on the left side the free complement concentration, and you see all values are very low. So under the it's normal, and the free C5 concentration also. So the drug works as complement inhibition. The advantage is the way that the protein is made makes that it has a much longer survive half time, so that you should dose it only every 4 weeks. Next slide. What are the results? Well, here you see that on the platelet count, you have a very fast normalization. GFR is normalizing and LDH is decreasing. That's what we are seeing with the previous, with the eculizumab also. But it's very predictable and reliable. Next slide. So it's bioequivalent, and you need to give it less frequent. But many questions remain open. If we are looking, most of our patients, I have just mentioned, we're starting with the therapy on a moment that we are not sure of the diagnosis. So what if after 3-4 days there comes another diagnosis out? And I remember once that after 48 hours the child had apparently pneumococcus infection. What was not clear. I think then you would prefer to have a short acting and not a long acting one. I think there are, for pregnancy, there are on this moment very limited data. The drug is not tested in small children, so there is no label in the small children. And of course, for the off-label indications, there are no data at all. So next slide. So this was these were the 10, what I would say, frequent asked questions. Sorry that there went something totally wrong with the projection.
Thank you. Thank you for that, Johan, and your contribution, Aleksandra. It's a very complicated topic indeed, and there are many questions left. So I'm trying to see all the question marks in here. What we can tell about it. Let me check. But first, let me see if there are any questions from the audience. Okay. Maybe you help me a little bit with the questions.
Yes, I can help
Because
you.
I cannot.
No worries.
Yes.
So the first question is, what is the function of the complement?
The function of
the complement. Wow, Aleksandra, maybe there's a short answer for you from you. Is that a possibility? It's in general, of course.
Yeah, so it's a part of the immune system that innate immune system that acts against encapsulated bacteria, just like mentioned, meningococcal, Neisseria meningococcus, Haemophilus influenza, and Streptococcus pneumonia, and also against our own cells that are somehow changed.
Okay. Thank you so much. Okay.
Do you see the questions
now? The next
now?
one, please.
Okay.
No, not yet.
Okay.
I tried the question mark, but.
So you have to click on the question box, but I can also read them, no worries. So low C3, C4 means decreased production or consumption in disease activity.
Where does it come from, do you mean?
From Abdelhamid is asking that. Ramat. So if low C3, C4 means if there is a decreased production or a consumption.
How can we manage to elucidate that? Do we know? Johan, you're the expert.
Oh, this is difficult. I mean, in the majority of patients that we are discussing here, it's clearly that there is a complement activation. In the majority of cases, it's because of the inhibition factors like factor H and factor I are not there. I mean, of course, your endothelium plays also a role. So your CD46 or infectious agents or whatever are giving that also. I think complement is activated by everything. I think in this, there are no really patients with deficient complement system that would cause TMA.
Okay.
Okay, then thank you. Then the next question is about vaccination in patients with HUS who have not been vaccinated before HUS diagnosis against meningitis. So do you do a pause between the eculizumab injection and vaccination injection? If so, how many days?
I think it does not matter. I think in many countries, you need to have the vaccination before you can administer the eculizumab. I think because nobody wants to give the drugs if you are not vaccinated. But it takes time before your vaccination gives you coverage. So it does not matter. I think the lesson must be said, if you use this drug, you induce a complement deficiency, your patient must be maximal vaccinated.
Yeah, but you can start on penicillin as well when you vaccinate and then go to the eculizumab. Yeah.
Yeah.
Okay.
Yeah, because this person also adds, after a full course of vaccination, do you stop antibiotic prophylaxis? He usually stops after 2 weeks. She usually stops after 2 weeks. Do you agree?
Yeah.
Seems reasonable.
Yeah.
Yes.
With rafulizumab, it will be longer.
Mm. Yeah.
There's
Okay.
another question to Johan. To individualize treatment with C5 inhibitors, is it sufficient only to determine CH50, or is it more convenient to also have soluble C5b9?
This is a difficult question because when we are discussing, it's about interruption of therapy, if I well understand. I think,
Yeah.
Yeah, I think it's about risk analysis. I mean, that's what I mentioned. I think in the future there will be centers who are saying, I'm interrupting the therapy and I look when there is clinical relapse or not taking in account what is the risk factors. And certainly that is defendable if you are timely seeing your relapse. There will be others, and you have seen the difference, for example, in the transplants, who are saying we leave the stopping in the children without high risk profile. But high risk profile never means 100% relapse. That's not the truth. And I think that's what we have to counterbalance: the side effects of long-term complement inhibition and the risk of meningococcus. I think on this moment, and that's my personally, but I might be a little bit too be French indoctrinated, that I still in favor of differentiating between the high risk and the low risk groups. But it's indoctrination. I think on this moment, the group of naming stops in every patient after 3 months, and I think it's as well defendable, and it's cheaper.
Yeah. And sometimes they use as well eculizumab levels to see whether the dosage is okay. And you can
But they have stopped with that because it's a little bit too expensive.
Yeah, that's true. Yeah.
Yeah.
And thank you. We have actually many questions. So if you do not mind, we can maybe extend 5 or 10 minutes to answer all of the questions. So is there any prognostic or diagnostic significance of BP fragment in HUS management?
I think looking from pathogenetic point of view, yes. Looking from clinical point of view on this moment, no. I think it will not, on this moment, it will not change your attitude to therapy. I think what would be very important if we would have a very simple complement bedside test that we could monitor that, but that is not the case. So it's for research very important, but for clinics in this moment, I don't know any center who would use it.
Okay. So the next question is, in a secondary TMA, how long to wait before decision to start eculizumab? So how long to wait before you start the eculizumab, or as early as possible, as in primary TMA?
Can you repeat the question?
Yeah, so for secondary TMA, how do you decide when to start with eculizumab? Do you do it as early as possible, like in primary TMA, or do you decide differently?
Oh, this is an extremely difficult question. I think, first of all, secondary is off-label. Second, it's mainly, if you are not taking the Vtexit, it's mainly in adults. I'm pediatric nephrologist, I don't know. I think if you look to the data, there are if they are started in a medical need program, they are started relatively late, and not like in the others when you try to start as early as possible, simply because the drug is not easy to get. Where I would like to favor that, but I doubt if it's political correct, but I think within ERKNet it would be wise if we would write up strategies that at least everybody is following a certain strategy, that we can analyze it. Where on this moment, I mean, everybody does something else, and we will the company will never study secondary. I mean, there's no doubt. They have their labeling, their patent is running. No. If it's complement mediated, I think you should do it early. And I do remember for myself a child with very clearly post bone marrow who had all the criteria, where we discussed quite long, so 10 days before we were starting, and then the kidney did not fully recover. So the price with late starting is that you are losing effect. But I have not thought that effect is
but in adult nephrology, but in adult nephrology, they always start a plasmapheresis, and then they are going to think.
Yeah.
Thank you. Sorry.
No, but in children it remains difficult considering the large side effect ratio.
So there's a question regarding levels of C5b9. Is there any evidence about therapeutic influence on stop therapy with anti-C5?
No.
Okay. This was fast. So next question. On what basis we will take a decision to stop complement inhibitors? Is there any taper? What would be a prophylactic doses with this?
Well, I will make a promise. Within 6 months, there will be a consensus. I think the IPNA guideline is going quite fast. So I think there will be consensus, which I would say fork, because it will also some freedom. But I think where we were looking 3 years, 4 years ago, a little bit reluctant to the Dutch experience, I think that if we are looking to what Aleksandra was showing, that the majority is getting it 3 or 4 years, that will not longer be the case. There is, and I think old crocodile, I do remember several patients in time who got atypical Hus, who got plasmapheresis, there was no eculizumab, and who are 20 years later never got their second attack. So if we are honest, we know that there are patients who never needed also in the past treatment.
Yes.
Then there's a question on infection-related TMA. How long does it persist before it goes away?
Infection-related, the question is, what do you mean with infection-related? I think if you are thinking on influenza and this kind of drugs, or even COVID, I mean, then it's very clearly that it's an acute event. But there are certainly atypical cases or complement mediated who are activated on the moment of the infection. So in infection, who has it, you should look for the mutation. I think the topic of pneumococcus is totally different. I mean, there you have an enormous disease, and I think your TMA is maybe on that moment even your minor problem. It's often in life-threatening conditions.
Okay, thank you. Then the next, we have 2 more questions, and then you have managed everything. Is it possible to give every 3 weeks instead of every 2 weeks eculizumab?
Every 3 weeks?
Instead of every 2 weeks.
I would even say every 4 weeks in the majority of patients. I think with the evidence that we get from the Dutch experience, and that's now large enough, it's bigger than their publications. Yeah. But even then, I should say, but in the low risk cases, you might even try to stop.
Yeah, but you have to monitor the patient, of course.
Of course.
Yeah.
Yeah, but I think the risk of meningococcus is a realistic risk.
Yes.
So the next question is about terminal complex levels. So in patients with initially elevated terminal complex levels after starting C5 inhibitors, would you suggest following terminal complex levels during treatment and use it as a decision for C5 inhibitor discontinuation?
Oh,
I don't know.
I think this is on this moment research. I think it's still that that's what I mentioned. It's still that the indication for the treatment or the interruption are clinics, not measurement. I think everybody would like to have a simple chip where we are demonstrating all complement activations, but we all know that complement tests are not always documenting that there's complement activation. You have complement activated who are having normal levels. So yeah.
It's for the
I
future.
see that Ans agree with me.
Yes, it's for the future. We wish to have such a test, such a bedside test. It'll come, but we'll wait. Yeah. That was the last question.
This was the last question, so thank you so much, everyone. Yeah, today we had some technical issues, but we will, of course, as always, upload also the slides. So for the middle part where maybe the slides were not visible, you can also have then a look later on. But overall, I think it was a great webinar, and thank you all for your nice work. And yeah, I think we can end the webinar now and have a nice evening.
Thank you. Thank you for understanding and all the things you did before this presentation. Thank you so much. See you next time, maybe.
Thank you.